Welcome back to the Deep Dive. Today we're tackling a really big topic in mental health right now. It's this tendency, you know, to get hyper-focused just on the brain.
Yeah, absolutely. We're looking at sources that help us step back, recontextualize things like psychiatric disorders. It's about seeing that understanding illness, well, it takes a lot more than just mapping neural circuits.
So that's the mission then, to get the bigger picture.
That's exactly it. If you really want to understand mental health, just looking inside the skull, it's not enough, not by a long shot. We need like three different lenses working together.
Okay, what are they?
Well, first, the social and cultural world we live in now, how that shapes illness. Then we need to look way back at our evolutionary history to understand why we're even vulnerable to these things.
And the third?
And then with that context, we can finally make sense of the vulnerabilities in the brain mechanisms themselves. It's about pulling all that knowledge together, you know?
Got it. Synthesis.
Yeah.
So where do we start? Feels like we have to address the elephant in the room first, all the attention on the brain.
Right. Let's start with the critique of neurocentrism. That's the idea. And it's really popular. That human behavior, mental illness, it's all best explained just by looking at brain activity.
And what fuels that? Why is everyone so fixated on brain scans?
Honestly,
Mm.
a lot of it is the visual appeal. It's powerful stuff. Tom Wolfe actually saw this coming ages ago. He talked about fMRI, functional neuroimaging, and predicted these vibrant and arresting brain images would basically take over.
So the colorful pictures draw us in.
They do, but they also create this kind of mental shortcut, a fallacy, really.
Okay, so what's the error? What happens when we see those images?
That brings us to neorealism. It's a term Eric Racine coined. It's this flawed tendency we have to see those brain images just because they look so technical and bright as somehow more real, more valid than just looking at how people actually behave.
We trust the picture more than the person.
In a way, yeah. We confuse the pretty scan with the territory, which is the messy reality of someone's life and actions.
That sounds a bit like naive realism, you know? Believing the world is just exactly how we see it.
It's very similar. It's an old human bias. Think about people believing the sun went around the earth. Why? Because that's what it looked like.
Right. Your senses tell you one thing.
Exactly. And Galileo said overturning that required a kind of rape upon the senses. It's uncomfortable. Overturning neorealism means accepting that a brain scan shows correlation, maybe, but it doesn't directly explain why someone did something or what they intended.
And that distinction gets really critical in places like, say, the courtroom, neurolaw, or neuroeconomics.
Oh, absolutely. Imagine a lawyer showing a scan, pointing to some blob of color and saying, see, his impulse control circuits are different. The implication for the jury, for the public, is
But
haunting.
he couldn't help it. It's hardwired.
Precisely. It creates this false choice. It's not me, it's my brain, as if those are two separate things.
They're not separate.
Of course not. But this focus purely on the mechanism leads straight to controversies, like how the National Institute on Drug Abuse, NID, calls addiction a chronic and relapsing brain disease.
Okay, but we do know drugs change the brain, right? That part's true.
Undeniably, substance use definitely alters neural circuits. No one disputes that. The critique isn't about whether there's change. It's about what that change means.
Meaning, does it remove the person's ability to choose?
That's the absolute core of it. Does the altered circuitry make the person incapable of self-control? The evidence, actually, suggests otherwise. They often retain significant agency.
How so?
Well, think about what addiction is. It's characterized by actions persistently seeking and using substances. These are behaviors. And behaviors, unlike, say, the progression of Alzheimer's.
Respond to consequences. Incentives.
Exactly. You can't reward someone out of Alzheimer's. But addicts do respond to incentives and penalties. There's a classic example, that Leroy Powell trial back in 1966.
Tell me about that.
Powell was a chronic alcoholic, appealing a public intoxication charge. And during the trial, he admitted something fascinating. On the morning he had to be in court, he deliberately had only one drink, the one his lawyer gave him. Why?
Because he knew he had to be there, he responded to the consequence.
He curtailed his drinking specifically because of the legal situation. That flies in the face of the idea that he was completely powerless over the addiction because of his brain.
So you're saying the focus should be less on just the brain state and more on the person's choices and the environment influencing those choices.
Very much so. And research backs this up. Studies show people with addiction can actively suppress craving signals in the brain. You can see on scans less activity in the ventral striatum by consciously focusing on long-term negative consequences. That engages the prefrontal cortex.
So the brain activity correlates with craving, but doesn't eliminate the ability to exert control.
The neural correlates and voluntary action can and do coexist. The neurocentric view often just misses the person, the mind, the motivation.
Okay, so if the brain isn't the whole story, we need to zoom out, look beyond the skull.
Exactly. We need to look at the context, the surroundings.
Mhm.
Which brings us neatly to transcultural psychiatry. How do social systems, cultural norms, shape how mental illness even looks?
Right, context is king. So how do we frame that? What are the key ideas here?
Well, clinicians need to move past just basic cultural competence, just being aware of different cultures. We need frameworks that tackle power and structure.
Like what?
Two big ones recently are cultural safety and structural competence. Cultural safety came out of work with Maori communities in New Zealand. It's about recognizing historical oppression, inherent bias, and making sure the care feels safe from the patient's point of view.
And structural competence.
It goes even broader. It demands we look at how big social structures, laws, economic policies, housing policies, how those things directly impact mental health. It means really grappling with the fact that concepts like race or ethnicity,
Right.
well, they're social constructs, right? Arbitrary lines.
But they have very real consequences.
Brutally real. They become embedded in systems through racialized processes, and that creates huge health disparities.
Which leads to some surprising data, actually. I remember reading that large surveys like the CPE and NCSR found something unexpected about prevalence rates.
That's right. Counterintuitively, maybe, many minoritized ethno-racial groups actually show lower overall rates of common issues like mood, anxiety, or substance use disorders compared to white Americans.
Why would that be?
It's often linked to the healthy immigrant paradox. People who immigrate are often healthier to begin with. Immigration itself is selective. But, and this is crucial, that health advantage tends to fade over generations.
How so?
Take substance use disorder risk among Asian or Latino populations. It tends to increase across generations in the U.S., maybe as people acculturate more to mainstream norms or face different stressors.
So lower prevalence overall for first generation, maybe? But it's not the whole story. You mentioned a nuance.
Yeah. Even if the overall rate is lower in some groups, when disorders do occur, they are often more chronic, more severe.
And why is that?
Often, it comes back to those structural factors. Systemic racism. Things like redlining affecting where people live and the resources they have access to, disparities in the justice system. It all limits access to good, timely care.
And that can even affect the diagnosis itself.
Hugely. Diagnostic bias is a major problem, especially with psychosis. Studies consistently show African Americans and Latinos are diagnosed with schizophrenia at much higher rates than white individuals, sometimes over twice as often for Black patients.
Wow.
And this bias isn't really decreasing over time. It can tragically mask other conditions like treatable mood disorders that get missed because of the focus on psychosis.
So what can clinicians do? Are there tools to fight this bias?
Yes. The outline for cultural formulation, the OCF, is vital. It gives clinicians a structured way to ask about cultural identity, how the person understands their distress, stressors, resilience, the relationship with the clinician. It's systematic.
And understanding their concepts of distress.
Crucial. You need to know the difference between cultural concepts of distress. Are we talking about a cultural idiom like butterflies in my stomach? Or a cultural explanation like maybe chemical imbalance? Or a full cultural syndrome like ataque de nervios?
And for treatment.
For actually negotiating treatment, the learned mnemonic is really practical. Listen to the patient's perspective, explain your own, acknowledge the differences, recommend options, and negotiate a plan together.
It's bringing the patient's cultural reality right into the room. We even see this down at the level of medication, right? Ethnopsychopharmacology.
Absolutely. Culture affects biology. Take drug metabolism. Differences in liver enzymes like CYP2D6 mean people of East Asian descent often metabolize certain psychotropic drugs more slowly. They might need lower doses.
Or the clozapine example.
Right. Benign ethnic neutropenia, which is more common in people of African descent, historically led doctors to underuse clozapine, a really effective medication, because of concerns about low white blood cell counts. The guidelines have only recently been updated to account for this known benign difference. Knowing the structural context changes clinical practice.
Okay, that's a powerful link from the social context right down to the biological, but it still leaves that deeper question, the why. Why are we like this? Why does evolution leave us vulnerable to things like anxiety, depression, addiction in the first place?
Now we're shifting to the third perspective, the evolutionary foundations. This asks the ultimate why questions. Nico Tinbergen, the ethologist, gave us the key idea here. To really understand any biological trait, you need two kinds of explanations.
Proximate and evolutionary.
Exactly. Psychiatry mostly focuses on the proximate. How does the mechanism work? How does it develop in an individual? But we also desperately need the evolutionary perspective. What's the history of this trait, phylogeny, and what was its adaptive function? Why was it shaped by natural selection?
So, why did natural selection leave us seemingly so flawed? Our sources lay out 6 main reasons, right? Let's go through them. The first one seems pretty intuitive. Mismatch.
Yes. Our bodies and minds evolved in a very different environment, the ancestral environment. Think about modern drugs. Pure, concentrated substances hitting our reward pathways. We're just not built for that. It's a mismatch.
Like our attention spans. Maybe okay for a hunter-gatherer, but not great for office work.
Exactly. Or diet and exercise patterns. Huge mismatch. The second reason is trade-offs.
Meaning you can't optimize everything. Every adaptation has a downside.
Pretty much. Anxiety is a great example. Being highly anxious helps you avoid danger, which is good for survival. But the trade-off is you're constantly stressed, maybe miss opportunities. Selection doesn't optimize for happiness, it optimizes for getting genes into the next generation.
Okay. Third reason, constraints. Evolution isn't an engineer starting from scratch.
Right, it's a tinkerer. It can only modify what's already there. Think about the awkward design of the human birth canal constrained by the shift to walking upright. Or maybe why emotion regulation is so difficult. It's built on top of much older, more primitive brain systems.
What are the last 3?
Okay, quick rundown. Pathogens evolving faster than us means we sometimes have overly aggressive defenses, like inflammation, which itself might contribute to things like depression or even Alzheimer's. Then there's reproduction at the cost of health selection, favors traits that help reproduction, even if they shorten lifespan later.
And the last one is key for understanding symptoms, isn't it? Defenses.
Yes, this is huge. Most things we label as symptoms, pain, fever, cough, nausea, anxiety, they aren't diseases themselves. They are evolved defenses. Useful, albeit unpleasant, responses.
Which leads directly to the smoke detector principle. This really reframes anxiety.
It's such a powerful analogy. Think about a smoke detector. The cost of it failing to go off when there's a real fire is catastrophic, right? Death, destruction.
Right. But the cost of it going off when you just burn the toast is annoying. Maybe you wave a towel at it.
Exactly. The cost of a false alarm is low, but the cost of missing a real threat is incredibly high. So what's the optimal design for a threat detection system, like our anxiety system?
It has to be super sensitive. Set the threshold really low.
Precisely. It has to be biased towards false alarms. If there's only a tiny chance of a real danger, but the cost of that danger is massive, the system should trigger. So maybe 999 times out of 1,000, that panic attack feels useless. It's a false alarm.
But that one time it signals a real threat, it saves you.
And that's why the system is designed that way. Those useless panic attacks are actually the normal, expected output of a well-adapted defense system operating under uncertainty. It's not broken, it's working as intended, based on cost-benefit trade-offs.
That also changes how we think about low mood or depression, doesn't it? It's not just a glitch.
Potentially not. The idea is that low mood might be an evolved response triggered when you're pursuing a goal that's proving unreachable or yielding very poor returns.
Like banging your head against a wall.
Kind of. What's the adaptive function? Maybe to make you pause, conserve energy, stop wasting resources on a fruitless effort, and maybe reconsider your strategy. Think about trying to forage for food in the dead of winter. Persisting endlessly might be maladaptive. A period of withdrawal and low energy might be protective.
Okay, so this evolutionary lens gives us a totally different perspective on symptoms. How does this translate into clinical practice? How does a clinician actually use this?
Well, it helps structure how you think about the patient's problems. Instead of just a list of symptoms, you think about their life in terms of effort allocation, behavioral ecology, basically. There is a clinical tool mentioned, the review of social systems.
Let's see. Social status, occupation, children, family.
Right. Income, abilities, appearance, and love sex. It's a mnemonic to guide the interview, thinking about where the patient is investing their effort, where the stressors are hitting these fundamental, evolutionarily relevant domains of life.
So it connects their current struggles back to these deep evolved systems and potential mismatches or trade-offs.
Exactly. It provides a framework rooted in behavioral ecology to understand the sources of stress that might be triggering these defensive responses like anxiety or low mood.
It really pulls everything together, doesn't it? from the critique of just looking at neurons,
To the huge impact of culture and social structure.
and finally to this deep evolutionary history, explaining why we're vulnerable.
That's the synthesis we were aiming for. You move from the micromechanism, critique its limitations, bring in the meso-level context, and then the macro-level evolutionary why.
The takeaway seems clear. Brain, mind, environment, you can't understand one without the others. But let's circle back to that neurocentrism point for a final thought. This whole discussion, especially around addiction and agency, it raises a really fundamental challenge, doesn't it?
It absolutely does. If we go all in on the hard determinist view, the idea that everything is just neurons firing, that we're just, victims of neuronal circumstances, well, it creates a serious intellectual and ethical impasse.
Because if we say free will or choice is just an illusion and focus only on the mechanical brain, what happens to concepts like responsibility, accountability, even human dignity? These are foundational to our legal system, our social interactions.
They are, and it's a tension that, frankly, science alone can't resolve just by looking closer at the brain. That ethical, philosophical dimension remains. It's something crucial to keep wrestling with.
A powerful thought to end on. This has been fascinating.
Indeed. We hope this deep dive provided some valuable new perspectives for your own learning journey. Thanks for tuning in.